We have a very comprehensive, updated national HIV/AIDS strategy, which of course, when you leave, you can get the strategy outside if you're here, or if you are streaming live, you can look at it.
So what are we doing, and what are we going to be doing to meet these goals nationally?
Our next panel will discuss what our federal agencies can do to align with this updated strategy.
So as our federal panelists come up, I want to just tell you a couple of things. We will be making up some more time by shortening lunch, and you'll hear about that later. Sorry. And just to let you know, I understand that we have more than 1,500 people who are streaming this event live. 1,500, did I hear you correct? Is that what you said, Miguel? Yeah, 1,500 sites. So more people than that, 1,500 sites. So we'll go ahead and get started. Please welcome Dr. Jonathan Mermin, who is the director of CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. And I'll just, as Dr. Mermin comes to the podium, I'll also introduce Dr. Antigone Dempsey, who is Director of Policy and Data for HRSA's HIV/AIDS Bureau, which administers the Ryan White program, and also for Dr. Bob Eisinger, who is the new Acting Director of NIH's Office of AIDS Research, which coordinates AIDS research across NIH's institutes and centers.
And remember, submit your questions for these federal officials using the hashtag HIV2020, hashtag HIV2020, and we'll ask some questions at the end of the panel. Thank you.
Mermin, right there, down low. That's it. That's it. Perfect. Thank you. Well, thank you, and congratulations, Douglas, and and to everyone who's been a part of this effort. Good afternoon. I do understand that myself and my two distinguished colleagues are the only thing standing between you and food and beverage. Today, I wish I could say that we're on the cusp of an HIV-free generation or an HIV-free country. But the surveillance data don't support that kind of optimism. And I wish I could say that we've eliminated the deep inequities that underpin the HIV epidemic in this country. But the data and many of our personal experiences don't support that. And today, I wish I could say that we've been perfect in implementing HIV prevention, because I know we have not. But I do think that the arc of the HIV epidemic in America bends towards elimination. And that today, more than any time in the past 30 years, we have the tools and the knowledge to reverse what is the worst epidemic in recorded history. Following the path laid out in the National HIV/AIDS Strategy will get us there. So this afternoon, I will briefly discuss why HIV matters, why NHAS tells us to stop doing some types of HIV prevention and start doing others, some new CDC activities and partnerships, and how we are using monitoring and feedback for action. So why does HIV in America matter? First, HIV continues to be a major public health problem. Today, 1.2 million people are living with HIV in the country, and the number of persons living with HIV, shown here in red, has increased about 60% in the past 15 years. Each year, there are about 50,000 new infections and about 20,000 deaths among people with HIV, a net increase of 30,000 people with HIV each year. This is good news, since it reflects improved diagnosis and treatment. However, it presents a challenge for prevention, as a stable incidence, shown in blue and yellow dots at the bottom of the graph, and effective treatment result in an increasing number of people with HIV who have the potential to transmit the virus. In addition, it's not possible to understand HIV in the US without appreciating that it is a quintessential issue of health inequity. As Dean Montgomery Rice highlighted earlier, African Americans are 8 times more likely to have HIV, and Latinos are 3 times more likely to have HIV than white Americans. These disparities are highlighted among women. For example, the number of women estimated to be diagnosed with HIV in their lifetime ranges from about 1 in 32 African American women to 1 in 526 white or Asian women. HIV prevalence is also associated with population density, region of residence, poverty, education, employment, and homelessness. In addition, men who have sex with men are more than 40 times more likely to have HIV than other men and women. Yet, we have seen partial success. From 2002 to 2011, annual new HIV diagnoses decreased 33%. This was not because we stopped testing people. In fact, the proportion of persons with HIV aware of their status increased from 77% in 2002 to 87% in 2013. And from 2008 to 2010, estimated incidence decreased 15% among heterosexuals, 21% among African American women, and 22% among people who inject drugs, showing that we know some of what needs to be done, and when done well, we can tackle the prevention challenge. But 65% of new infections in the US are among MSM, and new infections increased 12% among men who have sex with men. There's a 22% increase among young MSM, particularly among young African American gay and bisexual men. We will need to do more of what works with greater reach if we are to reverse the epidemic among MSM, mostly because prevalence is so much higher among MSM than among heterosexuals, so the chance of meeting a partner with HIV is 40 times greater. In this figure, I wanted to reflect on this disparity, probably one of the greatest in public health. Ron Stahl and colleagues estimated the lifetime risk of acquiring HIV among all MSM, shown in the green line, and among black MSM in the orange line. If current trends continue, half of today's black MSM will have HIV by the age of 35, and for MSM overall, half will have HIV by the age of 50. I wanted to highlight these issues because it's the social and economic context that turns disparities into inequities. And for many of us, it is the desire to fight for equity that has drawn us to healthcare and public health. And the model data here present a clarion call for rapid effort. The first line in yellow represents the current situation in the US, where the stable incidence in 10 years, there would be 550,000 new infections. The blue line shows that if we reduce incidence by 25% over 10 years, we would prevent 62,000 infections and save the healthcare system $23 billion. But if we meet the strategy's 25% goal over 5 years, as shown in red, then we would save over 100,000 infections and $42 billion. Faster action now saves lives and resources later. So lastly, just paying attention to health equity while we expand new interventions and programs is going to be essential if we're to avoid exacerbating existing disparities. For example, despite the profound reductions in mortality provided by highly active antiretroviral therapy when it was first introduced, over an 80% decrease for men and women of all races and ethnicities, inequities in the rate of mortality between blacks and whites doubled between the early 1990s and the mid-2000s. We should not repeat the same mistake as we progress with new interventions and programs over the next 5 years. So now, why does NHAS tell us to stop doing some types of HIV prevention and start doing others? Primarily because not all interventions are effective, and not all effective interventions are equal. At the time of the first strategy, we examined our portfolio and found that although we had been focusing only on funding scientifically proven effective interventions, several were estimated to cost over $1 million per infection averted, compared with many others that were cost-saving. We needed to prioritize. We wanted to have the greatest impact by supporting the most cost-effective combinations of scientifically proven, scalable interventions directed to the right places, populations, and strategies. And this slide will represent a flow of high-impact prevention. For each potential intervention, we assess its efficacy from either randomized controlled trials or structured studies, and ideally, its effectiveness in uncontrolled real-life circumstances, which could be different. For example, for condoms, the best case scenario for efficacy is over 90% reduction in acquisition of HIV, but its user effectiveness rate is about 80%. It's necessary to consider economics too. Since we have limited resources, maximizing prevention means achieving the lowest cost per infection averted or quality-adjusted life year saved. Along with economics, we want to determine the feasibility of full-scale implementation, since interventions need to be at a sufficient scale. For example, a trial of 5 two-hour behavioral counseling sessions among women doubled condom use. But the target population was several million. We develop epidemic models to project the impact of interventions together. For example, implementing CDC's testing guidelines combined with expanding ART prevents more infections than either alone and is more cost-effective. And based on all of this analysis, we prioritize the interventions that will have the greatest impact and implement and evaluate these programs, and then feed it back to do a better job with everything else. To be most effective, we also need to consider new science. And although Dr. Eisinger will talk more about this, I thought it was important to just highlight a few issues. For example, ART reduces transmission of HIV by at least 96%. And data presented last week from an NIH trial shows that it benefits health regardless of CD4 count. HHS treatment guidelines just gave treating all people with HIV an A1 recommendation. Yet, in practice, viral suppression rates in the country are poor. Oral pre-exposure prophylaxis, taking medication when one partner is HIV negative to avoid getting infected with a virus, reduces HIV acquisition in heterosexuals, men who have sex with men, and people who inject drugs. It's over 90% effective when adherence is high. And CDC recently issued recommendations for a new HIV testing algorithm that detects infection only a few days after PCR positivity, greatly reducing the false negative rate and assisting with rapid diagnosis of people during acute infection when they're most infectious and they can be told that they have HIV and access treatment quickly. And on the near horizon, we see long-acting ART for treatment and PrEP and the potential for microbicides and vaginal rings. So I also wanted to give a few examples of how CDC has responded to NHAS through new activities and mention that aligned with the fourth NHAS goal, we've greatly expanded relationships with other government agencies, especially HRSA, SAMHSA, FDA, and the Department of Justice, as well as several others. And we've issued several joint funding announcements for the first time. So NHAS called for strategically aligning resources with the epidemic. An example is our Health Department prevention funding announcement that aligned funding with the epidemic by providing $339 million annually to states and territories based on their HIV prevalence. This changed allocations, and as can be seen on the orange map, resource distribution now matches the blue map of HIV prevalence. The funding announcement allows flexibility based on local epidemic modeling and need, but requires that 75% of each jurisdiction's budget is spent on 4 key strategies, including testing and treatment and improvements along the continuum of care. Another example is our care and prevention in the U.S. cooperative agreements. This is a partnership with HHS offices, particularly Ron Valdesari's, HRSA, and SAMHSA, and it provides $45 million of total funding over 3 years to 8 states. Eligibility was limited to states with the highest HIV burden among African Americans and Latinos and high AIDS diagnosis rates. Health departments are asked to overcome the social determinants that prevent reaching a suppressed viral load for people with HIV, increase the proportion of people with HIV diagnosed by expanding and improving HIV testing, and optimize linkage to retention in and re-engagement in care for people with HIV. And we have 2 other recent activities that I wanted to mention. One is our new community-based organization funding announcement that involves $216 million over 5 years, provided directly or through a partnership to 137 organizations. These are all working in high prevalence jurisdictions with populations at high risk. For example, African Americans, Hispanic and Native men and women, MSM, and transgender persons. We support testing and improvements along the continuum of care, and we empower people to protect themselves, including through the use of PrEP. A second FOA involves state and local health department funding focused on MSM of color with 2 prime goals. The first is improvements along the continuum of care and use of PrEP, non-occupational post-exposure prophylaxis, and effective risk reduction. And 2, use of surveillance data to improve individual health outcomes, something we call data to care. So it's apropos that Douglas Brooks held this event here at Morehouse School of Medicine. To do better along the continuum of care and truly improve the health of the public, we need to merge the goals of clinical medicine and public health. Clinical care tends to focus on the inner circles, patients prescribed ART or receiving regular care. Public health focuses on the outer circles, all people with HIV, whether diagnosed or not. We need to increase the scope of responsibility for all parties, so the public health system monitors outcomes such as viral load suppression and holds the healthcare system accountable. And clinics strive to improve quality of care, including preventive care, for a larger scope of patients, even those who have fallen out of care. And to do this, we really need to monitor and provide feedback for action. So we produce three main types of routine reports intended to improve public health and hold ourselves accountable. The first is a national progress report aligned with the NHAS indicators. And on the left, you can see an example showing the target of 90% for the proportion of people with HIV who know their status, and where we are now based on the most recent surveillance data. On the right is an example from our state progress report that shows how well each state is doing compared with other states, the average, and the national goal. In this case, there's a very concerning variation in one of the most important indicators available, death rates among persons with HIV infection. For example, a person with HIV in Louisiana is twice as likely to die than a person with HIV in Virginia. We are also increasingly using these types of reports for our direct grantees using a semi-annual rapid feedback report. So we ask our grantees for information, and we're obligated to provide it back to them in a comprehensive way so they can make use of it. So in conclusion, the HIV burden in the US is growing, and it includes extreme health disparities. Following NHAS has potential to reverse the direction of the epidemic among MSM and continue declines among other highly affected populations. Where we put resources matters, and it behooves us to do it right. And changes in the healthcare system and new science provide us opportunities to do an even better job over the next 5 years. Thank you.
Great. Thank you. Hi, everyone. Again, my name is Antigone Dempsey, and I bring greetings from Dr. Laura Cheever, who is the Associate Administrator of the HIV/AIDS Bureau at the Health Resources and Services Administration, and she was unable to be here today, but she sends her greetings. I'm also joined today by Dr. Deborah Parham-Hobson, who is our lead for HIV at HRSA as well. So today I'm going to be quickly going through some of our updates because also Jono talked on some of the points that I was going to talk about federal partnerships. So I already figured out I can cut time there. Yes. All right, moving on. So Douglas is going to keep me on point here. So it's first to acknowledge that August 18th will be marking the 25th anniversary of the Ryan White HIV/AIDS program. And that is I think a huge thing, yes. So the theme that we've put together for this is moving forward with care, building on 25 years of passion, purpose, and excellence. So this is a significant milestone for our community. It's also an important milestone for myself. Just 2 months after the CARE Act was passed, I was diagnosed with HIV in 1990 when I was 22 years old. And thank goodness there were services there for me, because I am here today because there was care, there was support, and my family was there for me. And I think that, if you were to ask me 25 years ago, would I be standing up here today, a little rushed, albeit speaking on behalf of an amazing program and on behalf of work that, many people in this room are doing, I would have thought that there would be no way. Because, oh, thank you. And I think it's just really important to remember those who are with us and who are no longer here. We carry their spirits with us, and I wish they were here, but they're not, and we hold them in our hearts. So this is just our framework, and I'll talk really quickly about this. The important part about this is that at the center of the Ryan White program is the comprehensive care system that is also linked with a public health approach to really make sure that people are engaged in care, accessing care, and reaching viral suppression. And then the petals around this, why do I keep getting this little clicky thing? Can you get rid of that? Okay, yeah. So the petals around are just the other pieces that we really do to help do our work and make that happen. Next is, and I'm not going to go over this because I think most of you are aware of how the Ryan White program is run, but funding goes to cities, to states and the AIDS Drug Assistance Program. Part C goes to healthcare agencies. Part D funds women, infant, youth, and children's, and children. Part F funds our AIDS education training centers, special projects of national significance, dental programs, and minority AIDS initiative funding. So who do we serve? This is the other, I think, just if I leave today with you hearing one thing, it's that the Ryan White program serves over 500,000 people. In 2013, we served over 500,000 people. And that accounts for 2 out of 3 people living with HIV who are engaged in care. So 2 out of 3 of the people who are engaged in care are served by this program. So the role of this program in implementing the national HIV/AIDS strategy, the updated strategy, is so key and critical. And so we're really looking forward to be able to continue that work and to do that. Our program is really serving people who are disproportionately impacted. 47% of the folks we serve are African American, 23% are Hispanic. Close to 90% are living at or below 200% of the federal poverty level. And so that's, I think, a really important piece here. We're really serving people who are poor and underinsured and uninsured. Also, what's even more important to me is this picture. The statistics tell one story. This is a photo of people at our program. These are people receiving services every day. These are people providing those services. This is a community. This is how the work gets done, is by folks on the ground at the state level, at the community level, and making that happen. So we were able to go around and capture some images of folks, and I just want to ground us all, in that reality, and I think that's so important. So just really quickly on Goal 1, one of the biggest ways that we can impact Goal 1 through the Ryan White HIV/AIDS program is to continue to do what we've been doing, which is working to retain people in care and help get them virally suppressed. So on this slide, you can see our data from 2010 to 2013. This is from our Ryan White Services report. And so one of the challenges that we found is around retention and care. It's been very stable over this time. I mean, it's pretty good, but it's not, it hasn't been increasing. And that's something that we need to be looking at and trying to sort of figure out and understand better. On viral suppression, you see that we've been increasing that about 3% every year. So in 2010, it was about 69%, and in 2013, close to 79%. And so, but I'm going to talk a little bit about some disparities there, because I think, there's an overall picture, and then you have when you look at certain populations. But we need to continue to improve that as well. And Jana already talked about the integrated plans, but this is the other way that we're working to address Goal 1 is, really collaborating with our partners at CDC to streamline communication and coordination around the implementation of HIV prevention and care services. The integrated plans are really to help engage a broader group of stakeholders and jurisdictions, and to maximize federal and state, local prevention and care investments. I think, just to reiterate that previously, states had to submit 2 separate plans, one on prevention and one on care. And now, we can really address the HIV care continuum by submitting these integrated plans, and we're really excited about that. So Goal 2. One of the most important pieces for us around Goal 2 has been the implementation of the Affordable Care Act. We have been spending a lot of time figuring out how do we integrate with healthcare. And one of the, I think, important messages we've been trying to convey, and we've been really, I think, sort of honing and developing, is that the Ryan White program really supports a dynamic and complex system of care. We're not an insurance program that funds discrete services. So that system of care works very well to leverage insurance programs and to leverage Medicaid, and it has been for many, many years. But the need for the program, and in particular when we're talking about folks who are low income and are not reaching the outcomes that we're trying to reach. We've talked earlier about mental health, substance abuse issues, homelessness. We still need the services of this program, and to be able to help support that, because insurance coverage doesn't cover all of that. And here's just a visual of, just some of the ways that we've been working to do this. So we've been really working to help enroll people into healthcare coverage, support premium assistance, work collaboratively with the Centers for Medicaid and Medicare to ensure that people living with HIV are being served. Health literacy has been a big issue that we've been looking at addressing, and we want to continue to address in the future, as well as affordability, provider capacity, network adequacy, and all that good stuff. So reducing HIV-related health disparities and inequities. This past year, I've had the wonderful opportunity to be able to work with some of our partners at NIH and the Office of the Assistant Secretary for Planning and Evaluation on three consultations. And the first one that I'm going to talk about is we held a consultation with NIH to look at evidence-based interventions around trauma and HIV. And so, a bunch of the stuff that we talked about is looking at the impact of trauma on gay and bisexual men and women. And we had robust discussions about, assessment, referral, the impact of trauma, the impact of, mental health challenges for folks on people living with HIV, being able to access and really achieve the outcomes that we're trying to reach. And I think it really helped raise up some questions for us and ways to move forward to begin to try to address that with our partners. So in the other meetings that we had with OPAE, the first one was on improving care for women living with HIV, and the second was on trying to help address some of the disparities for young people living with HIV. And so for the women's panel, one of the things, a couple of the key things that we came away from that was that, we really need to be making sure that women are being served well across all the parts of the program, not just in one part, but all parts of the program, because all parts of the Ryan White program serve women, and it's important that we're meeting the needs of those women. And what we heard from panelists was that, we need to make sure to have a sexual and reproductive health services approach, and that the impact of trauma is real in terms of how well, women are living, and not just in terms of, outcomes. Maybe they're doing fine in their viral suppression, but, maybe they're having lots of other challenges that they're dealing with related to the trauma. The youth panel was fun in that we invited a number of youth activists, and they did what you do when you bring young people to the table. They broke the mold. So we came to the meeting, and we had a whole model up that had all roads lead to viral suppression. We had all these different interventions and all the sort of different things out there. And then the young people started talking about that when they go to their doctor, the only thing the doctor wants to talk to them is about being virally suppressed, and that they felt like the doctor didn't care about them. They didn't care about what was important to them, and that maybe that's not what's important to them. So that was, I think, very meaningful panel for us as well, and it's important for us to remember that we have to work in partnership with the folks that we're trying to help serve, because maybe what we think is right is not always right. So just a little bit about around health disparities. So this is our data looking at retention and care and viral suppression, and just to help save time, I'll focus on the viral suppression. And really, so this is just to show that, so in the viral suppression side, you see there is some increase. There's an increase happening in viral suppression, but there's still great health disparities and gaps, in particular for Black African American folks. And so even though we have seen progress, so we've seen a growth rate of 6% in viral suppression in Black African American populations that we're serving in the Ryan White program compared to 3% overall, there's still a huge gap there between the other populations, and there's still lots of work that needs to happen. We also see the same gap for young people. And again, we've seen some good progress over the last 4 years, a 10% increase for young people ages 13 to 24, compared to 4% overall by age groups. But again, there's still a huge gap that remains that we will be focusing in on, and we're so glad that the National HIV/AIDS strategy is continuing to focus on these populations. So just to really quickly, some of the projects and strategies that we're working on is best practices for engaging and retaining young and adult Black MSM into care, and we've had that cooperative agreement for the past year, and with NASTAD, and my colleague is in the room who's leading that project, and I don't see Terrence here, but he's in here. And they've been doing a great job on this, and we'll be looking to share lessons learned on that project in the next year. We've also been looking at how to build on social media strategies like texting and other ways to serve young people in particular, meeting young people where they are. We had a health literacy project for the past year, and we found this to be really important. We've learned that just because somebody gets an insurance card doesn't mean that they know what to do with it or how to use it or how to access services. And there's important health literacy things that maybe someone has never been exposed to that part of the healthcare system, and we can't, we have to make sure that we're helping them to, gain what they can from that system. And then also, we're in the next year going to have a new project on building awareness and capacity and engaging young gay and bisexual men and young women of color in care. And so I'm actually personally very excited about that one as well. So I also am able to announce for the first time today that the Special Projects of National Significance is about to launch. So we have a social media initiative, and we will be awarding 10 demonstration projects, and we have awarded the Evaluation and Technical Assistance Center, and that's totaling $3.5 million. So this initiative will be, yes, thank you. This initiative will be looking at different ways that we can use social media to improve retention and health outcomes for young people who are underserved. One of the things that came up in our youth technical expert panel was some of the young people talking about some of these texting things that happen, and they said, well, I don't like, if there's not a person on the other end, I don't care. I mean, they're very savvy. They know if it's like a computer sending them a message. And so they ignored it. They ignore it. And they want to know, is there a person on the other end of that text that I can talk to? Because, just getting a random text message is just not, maybe I can give them some information, but it's, not sort of what they're looking for. And that relationship building, that is what they're talking about. So I'm not going to go into these because Jono talked about them, and I'm trying to save time for everyone, although I will just talk about the HIV care and housing. So that's a new project that we're going to be starting, and we're working really closely with HUD, and Jono talked about most of the other ones already. But we'll be looking at how HIV housing data and integration can help improve health outcomes, because we think that's also very important as well. So why is the National HIV/AIDS Strategy important? And so I just want to sort of leave with this one thought. I think it's important because what we do matters, and Doug started earlier in the day talking about Black Lives Matter, and thank you for sharing that. I think that what we do matters, and it matters if we do it in a coordinated way on every level, and I think we can get to our goals if we do that. So this came true to me at the youth TEP. We were going around introducing ourselves, and when I shared my name and that I had been a young person living with HIV, one of the young people in the room, his mouth dropped open, and he looked like he had seen a ghost. And I was like, okay, I don't look that old yet. And I went up to him after, and I said, hi, what was that? And he said, when I was diagnosed, I found a book in a thrift store, and it had stories of young people living with HIV, and your story was in it. And I connected with it, and I didn't know if you were alive or dead, and it helped me get through such a hard time. And, so what we do matters. I wrote that story 25 years ago, and that mattered to him almost 25 years later, a young man, sort of where he was in a thrift store, which is crazy, but so. Thank you. Thanks.
Good afternoon. I'm Bob Eisinger, the acting as NIH Associate Director for AIDS Research at NIH. And I'd like to thank Dr. Rice for hosting us here at Morehouse School of Medicine and Douglas Brooks for inviting us to participate. My presentation will provide a brief overview of the NIH AIDS research that is supporting the NHAS goals. The NIH supports a comprehensive program of biomedical, behavioral, and social science research on HIV and its associated opportunistic infections, comorbidities, and other complications. Findings from NIH AIDS research is critical to providing the essential tools and strategies for HIV prevention and treatment, and most importantly, for accomplishing the NHAS goals. The NIH AIDS research program represents the largest public investment in AIDS research in the world. All of the 27 institutes and centers of the NIH support AIDS research, and it covers the continuum from basic research all the way through clinical trials and ultimately to the development of treatment guidelines and standards of care and translational research. Many of our studies are multidisciplinary and involve both U.S. and global investigators. Oops, sorry. There we go. To coordinate the NIH AIDS research program, the Office of AIDS Research was established in the Office of the NIH.Director with the responsibilities to plan, coordinate, and evaluate the NIH AIDS research program. Each year, the Office of AIDS Research, working with our colleagues in the various institutes and centers, as well as the scientific community and advocacy groups, develop an annual strategic plan that sets forth the scientific priorities, opportunities, and goals for the NIH AIDS research program. And it is updated annually to reflect the scientific advances and opportunities and priorities that we see. The OAR also is responsible for developing an annual AIDS research budget to ensure that resources are available to address the scientific opportunities and priorities. We also conduct program evaluations as well to ensure that the resources are indeed aligned with the highest priorities. NIH research supporting the first NHAS goal of reducing new HIV infections includes the discovery, development, and clinical evaluation of vaccine candidates, as well as new microbicide candidates and formulations. Dr. Mermin has already addressed the results from the HPTN-052 study, which demonstrated over a 90% effectiveness in preventing sexual transmission from an HIV-infected individual to their partner. And the durability of this approach has further been reported over time for both men and women. HPTN-067 discussed the acceptance and adherence to daily PrEP by young women in South Africa, young MSM in Harlem, as well as young MSM and transgender women in Bangkok. And that was the HPTN-067 study looking at PrEP. We continue to support studies looking at long-acting injectable antiretrovirals. And we also have an extensive portfolio looking at integrated strategies to prevent HIV, including combination prevention studies such as the POP-ART study, looking at community HIV incidence, and a number of programs that are targeted to enhance testing, linkage to care, and treatment services. Substance abuse treatment and HIV prevention is also a key priority for the NIH. Our responsibilities in AIDS research do not just end with a clinical trial, but we also support and co-chair the development of treatment guidelines, such as the prevention of mother-to-child transmission guidelines. In regards to the second NHS goal, NIH supporting research focused on increasing access to care and improving health outcomes, looks at various strategies to enhance testing, linkage to care, and treatment, which we call TLC+. The results from the START trial have been released, showing the critical importance to start HIV treatment as soon as diagnosis occurs. And certainly the integration of treatment and prevention for IDUs is another key factor for the NIH. We're supporting development of long-acting antiretrovirals and formulations and of new and better regimens that will permit easier adherence. Other studies that we support that are indeed aligned with the second goal deals with approaches to treat the various ART-associated toxicities and side effects. We also are developing new and better prevention and treatment regimens for the various co-infections associated with HIV, such as hepatitis C, TB, and malaria. And certainly the increasing instance of HIV-associated comorbidities is another priority for the NIH. And the results from these studies ultimately are translated into standards of care for adults, adolescents, pediatric cases, and PMTCT. The third goal of the NHAS of reducing HIV-related disparities and health inequities, NIH research is supporting studies to better understand HIV risk factors, prevention, treatment, and outcomes in racial and ethnic populations. We also have supported a number of initiatives that are ongoing, looking at sex and gender differences in regards to outcomes of HIV treatment, care, and prevention. And certainly implementation of PrEP is another key priority for the NIH. We've launched a number of new initiatives focusing on ways to characterize the HIV infection among Hispanic and Latino communities in the U.S., and we have also supported a number of new initiatives looking at increasing the number of minority investigators involved in conducting HIV research. We have supported a number of programs focusing on better understanding the epidemic among Black MSM. We've heard today the increasing instance of HIV new cases in this population, and so we are looking at the various risk behaviors, behavioral change, stigma, and social networks, and the rates of new infections and the factors associated with these new infections. Certainly the acceptability, safety, and feasibility of PrEP and its potential implementation among Black MSM is a focus area for the NIH. And the identification and linkage to care and retention in care is another priority. And finally, the NIH research supporting the fourth goal of trying to achieve a more coordinated national response to the HIV epidemic. NIH participates in several of the federal interagency working groups on HIV. We also have representatives from various federal agencies on the NIH Office of AIDS Research Advisory Council. They participate in the development of our annual strategic plan, and they also participate in the development of the treatment guidelines for adults, adolescents, pediatric, and PMTCT. This final slide is a series of linkages to various portals to try and find out if you're interested in finding out more about the various AIDS programs. The first, the Office of AIDS Research, the very first link, also provides an opportunity to see what the individual institutes and centers are supporting in regards to AIDS research and their funding opportunity announcements. The second and third links provide information on the various HIV/AIDS clinical trials that are ongoing. And the final link, and most important for physicians and healthcare providers and patients, is the link to the antiretroviral therapy treatment guidelines that HHS develops. Thank you.
Let's give our panelists another round of applause. Awesome, thank you. Well, we've had a full morning with great information, and we're looking forward to the afternoon. We're excited about that, where our community partners will discuss the updated strategy. But until then, it's time to eat. I'm a minister. You're supposed to say amen. Amen. Say amen again. Before we go to have lunch, we have a short video that we want you to see. And then immediately after the very short video, you will be dismissed for lunch, which will be out in the vestibule.
In 2010, the President launched our country's first comprehensive national HIV/AIDS strategy. It called on the nation to work together to halt the epidemic and it inspired a collective response to HIV.
It led us to really focus on increasing the proportion of people who successfully move through the stages of the HIV care continuum. And it led us to address the intersection of HIV, violence against women and girls, and gender-related health disparities.
The strategy also called on all sectors, from health and housing to justice and education, as well as the business community, faith communities, philanthropy, the media, and advocates, to align and coordinate their efforts.
Since its release, stakeholders from every sector have used the strategy as a roadmap. Important progress has been made, but still, much work is left to be done.
Today, it's clear that the next phase of this work will require an even sharper focus on delivering effective, evidence-based services to those who need them most.
Gay and bisexual men of all races and ethnicities.
Black women and men.
Latinos y Latinas.
Youth.
Transgender women.
People who inject drugs.
In the U.S. South.
To guide our efforts through the year 2020, the Office of National AIDS Policy, working with federal agencies and communities from across the country, has updated the strategy.
The vision and goals of the original strategy remain.
But the update integrates changes rooted in advances we've made and lessons we've learned since 2010.
To move forward, the update offers steps and actions to improve our collective response.
Widespread HIV testing and prompt linkage to care to people who test positive.
Support for people living with HIV so that they can remain in care and adhere to treatment.
Universal viral suppression to all persons living with HIV. And full access to comprehensive pre-exposure prophylaxis, otherwise known as PrEP.
The update also includes 10 indicators we will use to measure progress toward achieving the strategy's goals.
This is a national plan, not a federal plan.
This is our strategy.
This is our strategy.
It's all of ours.
This is our strategy. This is our time.
Learn more, including specifics, on the action steps and indicators at AIDS.gov.